Good evening, everyone. You're welcome on behalf of the AFRA Training Committee. I welcome you to today's webinar on medically assisted reproduction in the era of OMICS. This is a timely topic because ART is moving beyond conventional clinical parameters and embryo morphology towards deeper molecular understanding through genomics, transcriptomics, proteomics, metabolomics, and epigenomics. Key issue for us as clinicians is how these technologies can improve embryo selection, treatment individualization, endometrial assessment, and fertility outcome, while also recognizing the limits of evidence, cost, accessibility, and ethical practice. I would at this point introduce my co-moderator, Mrs. Inipi Uja-Samuel, to just give us some announcement before I introduce, read the profile of our eminent speaker for today's webinar. So, Mrs. Inipi, you have the floor.
Good day, everyone, and welcome to today's edition of AFRH bi-monthly webinar series. Like Dr. Fache rightly announced, my name is Inipi Uja-Samuel. To our returning members, welcome back from the short break. And to those joining us for the very first time, we are glad to have you here. Of course, we all know this community continues to grow, and it is a testament that the passion and dedication that drives the reproductive health professionals across Africa and beyond has to do a lot with Nigerians. So today's announcement is all about this year's conference, which is a landmark event. It's on the second. It's actually the second Congress of the African Federation of Fertility Society, the AFFS, and in conjunction with the Association for Fertility and Reproductive Health, AFRH. That's the 16th Annual International Conference. And the theme for this year is Fertility Frontiers, Global Innovations and Advances in Human Reproduction. And it is officially tagged as AFSS Abuja 2026. I want every one of us to please mark our calendars. Yeah, the conference holds on the 24th to 26th of September 2026. And of course, the venue is the Abuja Continental Hotel, FCT, Nigeria. Registration is now open. Kindly go through the flyer for the different categories of registration. We encourage you to take advantage of the early bird window, which has been extended over time. And of course, it was formerly 31st of May, and it was extended to the 21st of June, 2026. And of course, there's an early bird discount code to enjoy 50,000 Naira discount reduction across all the registration categories. So please review the flyer, the conference flyer, for full details and register at www.affsconference2026.org. For the abstract submission, the abstract submission is still ongoing. It's not ending on the 21st of June, but on the 30th of June, 2026. So, of course, we expect that wonderful works will meet up with this wonderful opportunity to showcase your research and contribute meaningfully to the growth of fertility care across Africa. Guess what? There are prizes to be won. I've announced it severally, and we have the categories best submission, in which it has two categories: the 100,000 Naira for best embryology abstract, courtesy of Mrs. Bobo Kayode Memorial Foundation, and 100,000 Naira for the best clinical oral abstract submission, courtesy of the conference LOC team. That has to do with presentation. So for submission of abstract, the guideline and format requirements, visit the AFFSconference2026.org/abstract/#. With that, you get all the guidance on how to go about the submission of the abstract. We also encourage you all to install the AFRH Nigeria app. There is no need to go to App Store. All you have to do is just use the link, visit the app, visit.app.afrhnigeria.org/install. That will give you the guidance to install AFRH Nigeria app on your devices. Now, kindly direct all questions.
Ask the lady waiting for me to please.
Kindly direct all questions in the course of the presentation to the Q&A chat box, and due diligence will be done to it eventually. And the reminder is that today's session is being recorded, and will be available for a replay on the AFRH website. Do follow us on all our social media platforms for the latest updates, and I trust you'll get all the feedbacks that you require. Thank you, and over to you, Dr. Fache.
Thank you, Mrs. Inipi, for that announcement. So I'll go straight to introduce Dr. Akinola. Dr. Lateef Adekunle Akinola is a distinguished obstetrician and gynecologist, reproductive medicine specialist, clinician, teacher, and researcher. He graduated from the University of Ibadan in 1985 and has since pursued extensive training in Nigeria and abroad, including an MSc in Human Anatomy and Embryology from the University of Lagos, a PhD in Molecular Reproductive Endocrinology from the University of Oulu, Finland, and an MBA in Health Services Management from the University of Plymouth, England. He has trained and worked in several reputable institutions in the United Kingdom, including St. Bartholomew's Assisted Conception Unit, Royal London Hospital, Newham University Hospital, Leighton and Dunstable Hospital, and the London Women's Clinic. Dr. Akinola has a strong clinical and research interest in reproductive medicine, assisted conception, ovarian function, endometriosis and adenomyosis, recurrent miscarriage, PCOS, fertility optimization, and high-risk obstetrics. He has published widely in clinical and research journals and continues to contribute significantly to medical education and reproductive health. He is also actively involved in professional leadership, serving as a member of the Executive Council and Editor-in-Chief for Sogan Lagos Sector and AFRH. He is a member of several international professional bodies, including the British Fertility Society, ESHRE, and ASRM. Currently practices in Lagos as a consultant obstetrician and gynecologist and reproductive medicine IVF specialist at Medicine Specialist Women's Hospital, Lekki. Distinguished colleagues, please join me in welcoming Dr. Lateef Akinola as he presents on medically assisted reproduction in the era of OMICS. Dr. Lateef, you're welcome, sir.
Thank you so much, Dr. Fache. Thank you, Mrs. Uja Inipi. I want to thank AFRH as well for this invitation, and we hope that at the end of this webinar presentation, we will all have a great idea about what OMICS is bringing to IVF in the recent times and in the future as well. So let me share my slides. You are all welcome. Thank you for being a participant in this webinar series. Okay, let's share. So can you see my screen, please?
Okay, yes, you can see your screen now.
Okay, thank you so much. Good afternoon. My topic today is on, I'm trying to limit this draw out. Okay, so my topic today is medically assisted reproduction in the era of OMICS. We all know that assisted reproduction has been on at least for over 4 decades, close to 45 years now, after the birth of the first IVF baby, Louise Brown, in Oldham, United Kingdom in 1978. We have our own in Nigeria in 1979, Master Uni. So our agenda today is on OMICS. What are OMICS? We'll talk about the core vision of OMICS, what OMICS contributes to IVF, the anatomy of OMICS layers, multi-omics and AI convergence, And of course, we'll also talk about limitations of OMICS and ethical imperatives of OMICS, especially in low, medium income countries like Nigeria. What can we gain from OMICS? We know that we are not in the forefront of research on OMICS, but we can benefit from the results of the research. What are OMICS? OMICS are large-scale approaches for studying the complete sets of biological molecules that make up and regulate organisms. Organisms like plantomics, zoonomics, these are involved in ethical research that is bringing the fruits of molecular endocrinology, molecular biology, and artificial intelligence to bear on fertility treatments. Different omics are available, as Dr. Fashe has mentioned. Genomics that studies the genome. Transcriptomics studies all RNA molecules. Proteomics, all proteins in a cell, tissue, or organisms are analyzed molecularly. Metabolomics, molecules and metabolites of metabolisms like uterine endometrial cavity or even gut microbiomes. Epigenomics, these are DNA chemical modifications that regulates gene expression in our body without any DNA change. Microbiomics are also available, interaction of communities of microorganisms like we have in the gut microbiome. Why omics are important in IVF or in disease generally, in molecular endocrinology generally, it makes us to understand the disease mechanisms, biomarkers of diagnosis. It personates, it gives us the leeway to personalize medicine, make it individualized, to study how genes and proteins and metabolites interact in our body, especially in cancer research. And this process also involves IVF, which is benefiting significantly from omics combination with artificial intelligence. A cursory look at PubMed concerning artificial intelligence in reproductive medicine from 1965 to 2026 this morning gave us about over 2,000 publications so far in the research. I'm sure it's much more than this. Of course, there may be some that are awaiting publications as well. And then tallying that with OMICS, we got 931, about half of what artificial intelligence in reproductive medicine is about. OMICS has been leaping forward in research, and especially in combination with artificial intelligence. We're going to talk about this in a minute. There's a problem with IVF, the compounding attrition of ART. We spent a lot of money. We expect 100% success rate, but we are not getting it. At least we know that there's a global burden of infertility, especially in low, medium income countries, where 17.5% of adults globally are infertile, 1:6 couples. Worldwide, there are over 3 million ART cycles that are performed annually. Yet the average live birth rate rarely exceeds 35 to 30%. 30 to 35%, with a sharp decline with increase in maternal age, which is compounded by additional environmental and lifestyle inhibitions. The above humbling reality demands molecular precision more than the current algorithms, empiric algorithms and morphological assessments that beset IVF at this moment. So how do we improve the fertility success rates, live birth rates, at least push it over 35% consistently? Some units are getting 60%, we know about that. And what are they doing that we are not doing that we could, be at par. Could we institute OMICS, artificial intelligence, molecular biology, and bring a significant improvement in live birth rate so that our patients will not wait too much, to achieve their aim of pregnancy. The status quo and limits of IVF. What are the limits? At the moment, population-based protocols, everybody is using protocols, SOPs, generalized algorithms that may not be suitable for all individuals. There is limited use and analysis of hormonal parameters and assessments, subjective visual grading of sperm fertilization, sperm analysis, embryo, and then making medically assisted reproduction expensive, repetitive, and emotionally draining for the patients and also for the physicians. What OMICS will contribute to IVF? OMICS technology captures biological complexity that traditionally IVF markers cannot. Key omics domain, as we have mentioned, genomics, transcriptomics, proteomics, metabolomics, epigenomics, are crucial assessments at the individual level. And this, if eventually it becomes, open to everybody to use, will, improve significantly pregnancy rates, live birth rates, cut down on the time from treatment to baby take home, and it's also going to reduce so much expenses associated with IVF. Transgenomics, as we explained, identified variants affecting ovarian reserve, sperm quality, embryo aneuploidy risk, and implantation failure. Transcriptomics defines real-time gene expression patterns in embryos and endometrium. Example, receptivity windows, endometrial receptive array that is, coming on board. It's been on for forever, and some units rely on it. Some units don't do it because of the expense. Hopefully, this expense can become dissipated over time, and everybody can have access to it. Proteomics also there, which reveals functional proteins driving implantation, immune tolerance, and embryo endometrial crosstalk. We also have metabolomics, which captures embryonic metabolic competence, follicular fluid health. And we know about this when we use spent media metabolomics of embryos to determine embryo competence and selection. Epigenomics assesses imprinting and developmental program and the risks associated if epigenomics go the wrong way. Significant shift to reproductive omics, the molecular precision era, that's where we are today. Subjective IVF has been beset with subjective assessments, morphological grading, visual trial and error, structural observation, empirical algorithms, while omics is bringing us into a more realistic world where we have objective measurements, multi-layered analysis, internal molecular architecture, and through this, we can have a predictive intervention rather than reactive intervention. You start a cycle, and then you are monitoring the patients, but until the patient is say, not giving you the required quality or quantity of eggs, then you intervene. That's accidental intervention. Rather than before you start the treatment, you already have the omics molecular structural results of these patients. You can plan the patient's treatment predictively. And this indeed has led us to this era of personalized medicine, individualized medicine, which is going to improve the lots of our patients and make us IVF physicians much more reliable, much more objective, and much more inclined to use molecular biology and systemic biology systems to solve all the problems we have now. Now, let's go to the individual, genomics. Onboarding genomics will eliminate, as planned, if everything works well, the research going on will eliminate recurrent implantation failure. These platforms, genomics, transcriptomics, epigenomics, proteomics, metabolomics, and microbiomics are completely interconnected. They can be used synergistically, where you have, especially genomics, which is much more represented by PGTA. And we know that the reality out there is that 40 to 70% of the 5 embryos from women more than 35 years are aneuploid. And this also does not exclude people that are less than 35 years, especially if they have problems with their genome. PGTA significantly reduces miscarriage, we know about that, and improves pregnancy rates in older women. However, we are sure, we know that in younger women, less than 35, the value is still up to debate. And this genomics, studying the genome of individual before we even start them on the IVF, has taken us out of this draft, algorithmic practice to precision era medicine. Let's look at transcriptomics, which defines a precise window of implantation. This is more or less like the endometrial receptivity array. That's been on forever. And we can see from this graph, look at this graph. This is the mid-luteal phase window of implantation. Not easy to detect without molecular analysis. We are currently using guesswork. We know that between day 14 and day 21, somewhere lies the mid-luteal phase implantation window. We are just doing like abracadabra. But now we are in the era of transcriptomics. If this becomes available to all clinics and the cost is not so inhibitory to every countries around the world, it's going to improve significantly the pregnancy rates of our patients, because transcriptomics are organized. They are organized from the pre-receptive endometrium to post-receptive endometrium. If you implant your embryo in pre-receptive, you already know the results, or post-receptive, you already know the results. But if you can, get accurately the day of implantation, or you just the window, day 1, day 2, or 3, then hopefully from genetic embryo transfer to timing to align with the patient's unique biological clock will become very workable. We can time it and work along with patient's biological system so that we can get the accurate time to implant. Proteomics and metabolomics, this, is more or less becoming commonplace now. That's what we call the non-invasive embryo assessment, taking spent medium from embryo culture plates, and then we analyze the follicular fluid for sperm proteins, identify critical markers for oocyte maturity and sperm capacitation. We can also use this metabolomics to study metabolic fingerprints, like amino acids turnover of the embryo directly from the culture medium. And without taking biopsy from the embryo, this reduces associated damage, cost, time, and dissatisfaction of negative results. So this non-invasive embryo assessment is currently on, and not all labs, good quality labs are doing it, but the cost is still a little bit workable and there are some 1 or 2 issues that may need to be resolved so that you don't get wrong results. Epigenomics and microbiomics, we know all about epigenomics. Epigenomics tracks long-term health, and IVF can cause alterations in DNA methylation. We know about that at imprinting control regions. So active surveillance required for rare imprinting disorders like Beowulf-Widman to ensure offspring safety. And microbiomics, studying the implantation environment, especially we all know now that chronic endometritis is a persist or is one issue that is very prevalent without announcing its presence. Unless you study, you target yourself to identify and analyze endometrial secretions and looking for the signature proteomics that you can study to assess this. This will improve endometrial toxicity or hostility to embryos, and it will also help us to target antibiotics, tailor probiotics that are emerging therapies to optimize the immediate anatomical environment, so that when our embryos are transferred, they will be in a very conducive atmosphere, and their implantation will be much more successful than what we have now. There are emerging horizons, single-cell multiomics, and we'll talk about that, cell-free spent media analysis. What are single-cell multiomics? These are specialized research methodologies to study individual cells. We can take the oocytes, study them, look at all the genomics, proteomics, transcriptomics, and there are research going on specifically to look at individualized cells and then focus on also cells-free spent media analysis. Hopefully, this will, eliminate the era of embryo biopsies. So we can know precisely when the genomic settings of our embryos are abnormal, or what the media we are using, the danger the media we are using or are causing to the embryos to prevent them from, reaching their potential to implant in the endometrial cavity. OMICS are good. They are revolutionizing IVF if well applied, but they have limitations. Like anything in life, there are also advantages and disadvantages, pros and cons of all sides of things. Now, massive amounts of data are generated by OMICS. You can imagine how much data is being generated from genomics, transcriptomics, and these overwhelm our capacity to interpret the data. Now comes the addition of artificial intelligence. Artificial intelligence, as we know, they are highly specific, very complex computer with significant high capacity RAM memories, and of course disk capacity. And putting the massive amount of data generated from OMICS into artificial intelligence computer complex can interpret, give us accurate interpretation, integrates the data from genomics to proteomics to metabolomics, give us accurate and precise analysis that we can use to predict the highly complex clinical and molecular data to provide a real-time decision support rather than being very reactive. There's a synergy going on now between OMICS and artificial intelligence, which is forming the new frontier of infertility analysis and treatment. This is a fundamental change, and it's redefining what ART and IVF should stand for. We are just scratching the surface of the potential benefits ART and IVF have. But with the combination of this artificial intelligence and OMICS, there is going to be a significant leap towards positivity. So traditionally, IVF, as we said earlier, is that we practice now is mostly trial and error, single biomarkers. We all use FSH, AFC, AMH. Retrospective audit we do all the time. We have given treatment to thousands of women. We analyze their data and see what the result is going to tell us so that we can now change our system. This is more or less retrospective, reactive activity. And then we use treatment algorithms all the time, cycle-based success. Whereas if we combine AI and OMICS in IVF, we can have a secure predictive modeling. A patient comes to your lab, you already study all our OMICS, you have a predictive modeling, how this patient is going to react to my ovarian stimulation, how this patient is going to give me the quality embryo, oocyte embryo I'm going to have. And this will cascade down to improved pregnancy rates. We use single biomarkers in the past, AMH. Now we are into era of systems biology. We study the human system to create a predictive modeling treatment reality. There's real-time, instead of retrospective audit, we are doing real-time learning, individualized treatments, and then lifetime reproductive optimization. We are moving from reactive protocols to predictive precision. Multi-omics and AI convergence. See, as I said earlier on, massive amount of data sets are generated from multi-omics, which is genomics, transcriptomics, proteomics, metabolomics, and microbiomics. Then come again with time-lapse morphokinetics. We all know how much data we can get from our time-lapse machine. And then couple that with patient clinical history. We can feed that into artificial intelligence, machine learning integration. And then we can have a predictive embryo ranking like IDA score. We can also use this to predict the patient's response to our therapy. We can use this to predict or to select quality embryos without any damaging protocols like biopsying the tufrectoderm biopsy or day 3 biopsy or blastomia biopsies. All this convergence will drastically exceed subjective reading or singular omics treatment. By combining multi-omics, we are moving forward with advantages that is accruing from amalgamating all the multi-omics together. What AI contributes, as I said, AI provides the ability to integrate, interpret, and predict across complexity. These are computer analysis, very, very complex. We've all heard about NVIDIA. NVIDIA is one of the top richest companies in the world, and they are producing significant amounts of incredible data, computer data analysis system that we can use to analyze all our data. So AI capabilities relevant to IVF, we know about that. We have talked about this before. Pattern recognition across high-dimensional or mixed data, integration of all the molecular system, transcriptomics, imaging analysis, clinical and demographic data of the patients. We can push that into our artificial intelligence complex, machine learning, and can give us a very predictive individualized treatment cycle for the patient. Continuous learning from our outcomes, live birth, miscarriage, obstetric complications, and then we can use all these data, from analyzed by artificial intelligence, from clinical decisions, intelligence layer, and biological truths to combine all this together into actionable clinical intelligence, pre-cycle actionable clinical intelligence that will give us a very, very accurate predictive results if all things work together. artificial intelligence converts OMICS data into actionable intelligence data, where we can use it to pre-treatment, prepare our patients for ovarian preparation and stimulation, endometrial receptivity, embryo selection, post-transfer. So all these are mapped out for us. We don't have to, do the guesswork, empirical, protocol-based, SOP-based treatment cycle. We are going to individualize system biology and molecular endocrinology systems to give us individualized stimulation vectors. That those are graph analysis of the patient dynamics, and you can use that to predict how this patient is going to react. You can use that to precisely calculate the dosage of your gonadotropins, when to give your HCG, or if you are using antagonist cycle, when to give your buserelin injections. And using the error, we can predict receptivity synchronization, and then embryo selection using multidimensional grading. And then post-transfer, we can predict precisely what the failure rate is going to be, what the success rate is going to be. So these all raise the prospects of improved successes with significant R&D associated and live birth rates improvements. Looking at AI and genomics, if we combine artificial intelligence and genomics, we are more or less looking at individualized ovarian stimulation. Genomic variants like FSH, LH, estradiol, progesterone. So we know that there are some patients that will, that are idiopathic empty follicle syndrome. And this has been categorized, most likely they have genomic variants. Using the genomic studies and research, we can use this to predict what their treatment is going to be, what we should be adding to their treatment cycle to, overcome their genomic deficiencies. We can use this to also predict baseline hormonal profile, and what this will interpret this as to how we can stimulate them. Historical cycle response we can also use. And this has significantly increased. If you look at it, we either globally or you look at it deeply, you will find out that this will, of course, revolutionize IVF treatments and success rates. And it's also give us the idea that this, because we can use individualized treatment cycle, especially in those women with very high AMH level, PMOS patients, the risk of OHSS risk will also be significantly reduced, because you are predictively giving them what they need individually, rather than using all the algorithms for PCOS, for high response, middle response, abnormal response, or low response. We can just use targeted omics system biology to predict their response. We all know about endometrial receptivity array and its importance since recurrent implantation failure. Using the biopsies from endometrium, we can study the transcriptomic profile, endometrial gene expression, hormonal dynamics, and combine this with historical cycle response of the patients to give us a particular window of implantation, which is going to be much more beneficial, much more cost-effective, and reduce psychological burden, and of course, make all of us physicians happy at the end. We are getting the results we need. Embryo selection, traditional assessments have been static morphology, and which is now giving way to next generation selection from transcriptomic metabolomes and time-lapse kinetics, PGTA integrity from spent media, So this provides a multidimensional robustness, and it's going to move us to when we can individualize treatment cycle, we can study their response to ovarian stimulation. We can proactively select embryos that are good quality. We can use PGT, ERA to predict endometrial window, normal embryos. Of course, we are moving on straight to the higher single embryo transfer success rates. We all know now that IVF is the commonest treatment cycle that produces most of the high order pregnancy that we see, and we all know the detrimental effects of triplets, quadruplets, septuplets, all those tuplets. We all know the detrimental effects. If we can use this next generation sequencing, transcriptomics, genomics, time-lapse kinetics, PGT integrity, well, we are moving closer to, you don't need to transfer 2 embryos. You don't need to transfer 3 embryos. 1 is enough. It's going to save our patients money, save them time to treatment to live birth, save them the psychological problems with repeated failures, recurrent implantation failures. So predicting and preventing medically assisted reproductive failures is one of the benefits, one of the main benefits of all these multi-omics that we are studying. And combining them with AI is fantastic. So this will lead us to high identification of high-risk ART cycles, allows the clinicians to pivot from reactive failures of targeted medical interventions or even cycle deferments. There are a lot of signature complex molecules we can study, from genomics to metabolomics, embryonic, OBGYN, medical history, and we can all use to the success, for the success of our patients and happiness of the clinicians. So the long-term vision is continuous updated AI and omics modeling of the patients, combining genomics, transcriptomics, proteomics, metabolomics, historical data, clinical acumen. We cannot do without clinical acumen. Experience of the physician is also, becoming vital in this process. And then we can use this as a process simulation of ART strategies before we go to the real world. You have all these studies. You can use it to predict what you are going to do for this patient before you even start the patient's treatment. All this to optimize and all the treatment cycles and improve pregnancy and healthy babies take home. What are the ethical imperatives of combining AI omics in the medically assisted reproductive systems? One, we know the problem of artificial intelligence. We need transparency, explainable models, avoiding black box. We want to know what the AI is analyzing. Are these important to me as a patient or to you as a patient or not? We don't want anything that will obscure our knowledge or what is actually happening behind your computer. I want to really know about it so that I can be rest assured that I'm in the right place. And then strict avoidance of racial and genetic biases. We all know that most of the data on multiomics, artificial intelligence is coming from the West. We are not doing much. And all these data are, derived from the West, the white racial connotations. So we find it difficult. I mean, it's going to be very difficult to just extrapolate their own data to what is happening in Africa. We have to be strict and avoid racial genetic biases. All this data should be individualized as to the most, commit to racial and racial genetic dissimilarity that exists in all individuals of the world. So we have to avoid that, not to just transport what is happening in the West straight to our own IVF laboratory system. We are causing irreparable discomfort and failures. If we do that, then we must be very sure about data privacy and equity. We all know artificial intelligence. We just open ChatGPT, we type something on it, it gives us the questions, but you don't know the data they are collecting from, from your system. They are studying you, they are seeing what you are doing, and there's no privacy. So how do we ensure privacy in all the information, especially if you are going to expose your patient data to the whole wide world of artificial intelligence? And there must also be equity. There must be rigorous clinical validation before real-world application. There has to be R&D clinical trials to make sure that what we are bringing into the real world is really, really important and is going to be, it is not going to be problematic and is going to be very, very effective before we start to apply it to the patients. Low, medium income countries, data sovereignty, the risk, I've mentioned it earlier, the risk of imported OMICS data sets and algorithm. And the risk is going to be made most likely that current OMICS data sets, European, North American, East Asian ancestry, compared to African ancestry, there may be data mismatch. African patient population are different genetically. So we need to, have massive support from the government to study our own genetic background. What is very, very much better. We know that there are specificity in terms of genetic disposition of all the races. We need to be very specific about our own genetic ancestry before we start applying OMICS data set from Europe, North America, and East Asia ancestry, so that we can avoid data mismatch, we can avoid problematic results at the end of our IVF cycle. The future is bright. Autonomous IVF is on the way. OMICS is going to complement that, and artificial intelligence is also going to complement that. So at the moment, there is no fear that robots are going to take over all the labs. As I mentioned earlier, human acumen is also very important. Without that, we are going to be, working in futility. These are my references. I want to thank you all for being part of this webinar up till now. And this is just to remind you about the coming second AFSS AFRH annual conference. This is going to be a global conference, bringing together ASRM, S3, AFSS, IFSS in Abuja Continental Hotel. It's going to be a massive event to attend. Please avoid missing this very important conference in Abuja. And currently, call for abstract is outside. And then we hope we are all going to reach out to our data and then submit fantastic abstract. We have it. So it's only a matter of going to retrieve the data, making it into a reasonable abstract form and submit it to AFRH. Thank you so much for listening while we await your questions. Thank you.
Yeah, so thank you so very much, Dr. Akinola, for that excellent and thought-provoking presentation. I've been looking at the Q&A box, and it seems as if I've not seen any question yet. Maybe because the topic is very quite advanced. Today's discussion has reminded us that medically assisted reproduction is moving beyond morphology and routine clinical parameters into a deeper biological understanding, the embryo, the gamete, the endometrium, and patient response. We have seen that OMICS offers exciting possibilities in embryo selection, endometrial receptivity, ovarian stimulation, male factor infertility, and personalized ARG care. However, we have also been reminded that innovation must be matched with evidence, affordability, reproducibility, ethical practice, and real clinical benefit, especially improvement in live birth outcomes. On behalf of the AFRH Training Committee, I sincerely thank our speaker, our participants, and everyone who joined this webinar. So we will take questions. We also encourage you to please participate in this bi-monthly educational webinar. And so the next webinar will be announced. But before we go, I think we'll take further announcement from Mrs. Inipi. While we await questions, please put your questions in the question box. Ask questions. Even if you want to ask Dr. Akinola his full name, you can ask that. At least there must be at least one question. Thank you. Ms. Inipi, you have the floor.
Thank you, Dr. Fache. Well, this has been a very rich and rewarding session. Sincere appreciation to you, Dr. Lateef Akinola. Indeed, you took us to the future. That's the word. And we trust God to help us catch up over time. Well, Dr. Lateef has already done justice to our announcement already. So very well, we are to all road leads to Abuja come 24th to 26th of September 2026, and the venue still remains Abuja Continental Hotel, FCT Abuja. Registration out of the goodwill of the leadership of AFRH, the extension has been ongoing, and 21st marks the end of the early bird registration. Please seize this opportunity, and of course, 30th of the month of June, this same month, will be the last line to collect or submit your abstract. And of course, it won't go unrewarded. All abstracts that stand out will be rewarded. 100,000 naira is up for grabs for the best embryology abstract, courtesy of Mrs. Bobo Kayode Memorial Foundation. And of course, 100,000 naira for the best clinical oral abstract presentation, courtesy of the conference LOC team. So look up, check the flyer for submission guidelines. Talking about, you can visit the AFS conference 2026.org/abstract/hashtag. And don't forget to install AFRH Nigeria app via visit app.afrhnigeria.org/install. And of course, with that, you stay connected with us on all our updates. Social media, we're everywhere. Social media, Instagram, Facebook, everywhere. Connect with us via social media, and all announcement updates will also be uploaded on those platforms. Today's session was actually recorded and will be available for replay anytime on the AFRH website. Our next webinar will be on the 24th of June, 2026. That's next week, Wednesday. And of course, a gentle reminder to us all as professionals, always keep your patients at the center of every decision you make in your facilities. I remain Uja Samuel Inepi. Over to you, Dr. Fache.
Thank you. Thank you once again, Mrs. Inipi, Uja Samuel. Dr. Akinola, there's one question here from Deborah Odegda. Thank you, sir, for this insightful presentation. It is exciting to see how AI, IVF, and OMICS are shaping the future of assisted reproductive technology. I have a question. Since much of the existing OMICS research has been conducted in non-African populations, and their ongoing studies focusing on African genetics and their impact on IVF outcomes. Given Africa's rich genetic diversity, I believe there is a need for more research, funding, and collaboration to ensure these advances are relevant and beneficial to our population as well. I believe this touched on your the last part of your presentation, but maybe you can re-emphasize that. Thank you.
Yes, thank you so much for that question. I think I clearly, mentioned this towards the end of the webinar, that it is not advisable for us to import data from the West, East Asian, and Mediterranean, where they have good R&D support from the government. All we need to do, here is to improve our governmental support to R&D, to institutions that are involved in research and development in the field of molecular endocrinology and assisted conception. We also need private contribution as well. I can remember, if we all remember, there is this very, very fantastic internationally supported company, 54 Gene, in the last few years, where we have the zeal to generate genetic data from Africa, specific to us Africans. But for some reason, the endeavor fall apart. And we have all the very expensive machines, because I visited their lab most of the time to see what they are doing. Fantastic machines, genetic studies, all data going on, then all those just vanish one day. And it's been very, very disappointing, to see that until we can have our own research backing, until we can have our own government supporting R&D in its all capability, we are just going to be scratching the surface. Some research is going on, especially in other well-developed African countries, but I can't see anything very substantial coming out from sub-Saharan Africa, especially, maybe even from other parts of Africa. We are solely rely on importing data, all the drugs, medications, whatever that are being experimented on the West and the white racial ancestry. We are just using it until we learn to study our own genetic ancestry, our own traits. Then we can use that to tailor our treatment modalities. We are just going to be, clocking what is not ours, and that may not be very, very effective in the long run. We have to encourage the governments, encourage private sectors, provide the architectural and infrastructural needs of individual private investors, give them tax exceptions so that they can invest all their resources in establishing all these very, very important research process. Thank you. You can look at the last few slides and you will see all the recommendations there. Thank you so much for the question.
Thank you, Dr. Akinola. I guess that's the only question we have for today. And on behalf of the AFRA Training Committee, I once again sincerely thank our speaker, all participants, and everyone who joined this webinar. I am Dr. Moses Fache, the Medical Director of Procare Hospital in Abuja. So we look forward to seeing you in our next webinar. Thank you.
Thank you so much for attending. Bye for now until next webinar.